studies and different things over time. And I'm really excited to have her on because she's been working so hard for so long on trying to establish standards for everybody throughout the world on IV care. So it's an exciting day. Everybody can see here what you've done in the past, and I like for these conversations to be conversations and somewhat of an interview. And but Lisa, let's just start off with some of the basics about you. How did you decide to be a nurse?
It's really funny. I wanted to be a nurse when I was just a little kid. You know,
Oh,
I remember drawing a picture. I still have the picture. I want to be a nurse when I grow up, and that kind of continued in high school. I still wanted to be a nurse, and I was a candy striper, working in the hospital, and that was like so much fun for me. And then I went right out of high school to UW Milwaukee, got my
okay.
BS on, and I very quickly went right back to graduate school as well because I really wanted to be a clinical nurse specialist. So worked full time in the hospital and went to school at night and eventually got my master's as well. I
I
never
did
looked
that
back.
too. Were you married at the same time?
Um, I got married at the end of just finishing grad school.
Okay.
Yeah.
Okay. When I finally finished grad school, my wife, it was a big sigh of relief for everybody at the house. So I know what
Yeah.
it's like.
It's a lot.
So
It's a lot of work, especially when you
so
work full time.
where in that procession of work and everything did you figure out vascular access was your passion?
It's really kind of funny because I was a hospital nurse, surgical floor, surgical ICU. I became the educator for our surgical ICU. And then we merged with the cardiovascular surgical ICU. And I had less seniority than the other educator, so I couldn't keep my educator job, but I still loved the practice. So I continued to work there. But as I finished grad school, a couple of my friends were really going to be starting a home care agency. And I was focusing in grad school on chronic illness and cardiovascular care and such. And I thought I would like to try that out just for something different because I'd worked in the unit for years. So I still worked in the CBICU, for quite a while of time after I started home care. And then I fell in love with home care. And that was at the time of the AIDS epidemic and home infusion be really beginning. So I was ultimately given a position to develop our home infusion program with our pharmacy. And, obviously I was good with IVs and things from my clinical background, but I took a class to learn how to put in PICs and midline catheters very early, the very beginning of PICS. And that's where it all started. I mean, I just fell in love with home care and home infusion, and I continued to see a lot of patients on complex infusions and manage them. And I've worked for actually the same organization for 35 plus years,
Oh, that's
many
amazing.
different names and growth, but same place, which is pretty interesting
So
to
during
me.
the AIDS crisis, were they trying to move more patients to at-home infusions during that?
Oh yeah. Those are when I
Everybody
was
was
seeing.
fearful of infections in the hospital.
Yeah, and they wanted to get out. I still remember the first patient that I taught how he needed to access his port. He chose to have an implanted port, for his antiviral therapy. And I remember going in the bathroom with him and, we're looking at the port, studying it and teaching him how to do that. So I remember him very well. And some of the patients on parenteral nutrition, those were some pretty sick patients that
Yeah,
we
yeah.
transitioned out. But I also remember a lot of the fear on the part of nurses, putting in a peripheral IV and, the fear of contagion. So it was an interesting time, but
Yeah, that's
um,
probably the closest thing to the pandemic, beforehand
mhm,
about fear of,
yes,
things spreading and things like
yeah,
that.
yeah,
Unknowingly, that
hmm
was always the fear was always the unknown, basically.
yeah, absolutely.
Yeah, yeah. Well, you've been doing INS stuff for 20 years. So how did you get
Yeah,
involved with the standards and get on the
yeah.
committee?
Well, interestingly, in the 2024 standards, this is my last time on the standards. There will be an afterword that I wrote, which will give a little bit of that history. But when I was developing the program, I was trying to reach out to any resources I could find, and then I learned about INS. I didn't know about INS when I worked in the hospital. joined it. And then we had a local chapter that was really quite active. And so I served in various roles, including president of that chapter, and then ultimately started getting involved nationally. I was on the education committee for a while, but what I really wanted was to be on the standards committee. So reached out to Mary Alexander in 2000 for the 2006 standards. I was on the committee. And then after that, I was given the opportunity to chair the committee after that. So
Okay,
it's kind of work that I
amazing.
love. So
Yes, yes. Well, that's great. So what's the best part of being on the committee, and what's the worst part of being on the committee?
the best part is just, working with your colleagues. I mean, they're all fantastic. We all come from different backgrounds. So it just, working together. I mean, we work separately on developing things, but we have, experts in all of our areas and people to reach out to. So that teamwork is very, very appealing. The work itself is laborious in a sense, but it's interesting work. To me, it's investigative in a sense. I mean, you're doing all of the literature searches. We had a librarian do our lit searches last time, which was wonderful. But just diving in and beginning to understand, the research, and growing and understanding research over time as we put together the standards. So I just think that teamwork, and it provided me a lot of opportunities that I didn't expect. Okay. I didn't
Mhm.
expect I would spend 2 years in a row, spend a week in the Middle East, teaching and going to China and Latin America and stuff. So I didn't anticipate that would happen, but it almost seems like a dream that I was able to do that and meet with so many nurses and physicians in different parts of the world to talk about our standards.
So over that long period of time, did you see some things, some trends of, whatever it is, technique or whatever with IV care that was heading a certain direction, and you thought that was going to be, the standard of care, and then research and everything, it swung back the other way. Did you ever see anything like that in that time period?
Yeah, I mean, I'm just trying to think of some examples of that. Okay, midline catheters, I think
Yeah.
might be an example. I remember when the first, well, there were early midline catheters. They were stiff catheters. They were used in the hospital, and even in my day. But then when the first generation of a midline catheter came out, and I learned how to use it, and myself and another nurse, we placed a lot of them. I even presented our outcomes. We had good outcomes on it. And then that kind of fell away for a while. And I
Now it's
think even
back.
right now, yeah, it's back. It's back in a different way. And certainly there's, new products, new techniques. And I think, we've learned a lot. But we still have a lot to learn as well. And right now, INS is, define the tip, the distal tip of the catheter, of a midline catheter differently than what's in Europe. So we need to look at all of that research. So it's like gone back and forth because we went from this, deeper placement away from the deeper placement, and now we're really going back, looking at that again. So
Right, right.
it is interesting. And I think,
Cyclical.
yeah, yeah, exactly.
Well, I think these next three slides are yours, kind of from your standard presentation. You want to guide us through this information?
Yeah, this is just a little bit of, how I educate our nurses. I do a class every month for the nurses that work in my organization, kind of an introduction and orientation to home infusion therapy, and talk about, our goal is to keep patients out of the hospital. And actually in home care agencies, it is a publicly reported outcome, hospitalizations. So when we look at home infusion, we don't see that many hospitalizations. Most of our patients are not. But it is a high risk area of practice because these patients have an invasive device and we have to care for that. They are at risk for complications, although in general, we don't maybe see some of the same level of complications in home care as you might see in the hospital, particularly infection. And what I have preached for years is that you have to have knowledgeable and competent nurses. You have to provide education, and that's still not happening across the board.
Yeah, I think you'll appeal for that for your entire life, right? I mean, that's always going to be the case.
Yeah. Scope of home infusion therapy just lists all the things that we do. Certainly, literally almost any antimicrobial drug can be given. Some of the antiviral drugs may or may not be better administered in an outpatient setting. Chemotherapy can be given. There's got a lot of safety issues around that. I've given a lot of chemotherapy over the years, but we're doing less so right now. for a number of reasons. Parental nutrition, I think that is a really complex patient group. I provide separate education on that topic. Those patients are complex, and they are some of the higher risk patients that may end up back in the hospital. They're at higher risk for a BSI. And the rest, opiate analgesics, mainly in palliative and hospice care. We could give hydration fluids that can keep people home. And then you've got some of the specialty areas, IVIG, subcutaneous IG, enzyme replacements, other biologic therapies. Those are things that I administer right now to the patients that I see. I'm kind of in that area of infusion. And then even cardiac. We were the first agency in the city, in the greater Milwaukee area to actually take patients home on a positive inotrope like dobutamine or milrinone for end-stage heart failure and as a bridge to transplants. And so those are some of the patients I really got involved with very early in my career.
Well, that was good coming out of the cardiac ICU.
It did.
So that's very helpful.
Yeah, I had total connections with the cardiologists as well. In fact, one of the cardiologists and I even wrote a little article for a physician newsletter about it.
Yeah.
And then this is my model. This I've published a number of times, but really it just talks about 5 things that really are going to impact your outcome, hopefully positively impact your outcome. Having a prepared home care agency with educated, competent nurses, policies, procedures that are up to date, appropriate patient selection. Not all patients are going to be appropriate for home care. Some may be better served in another setting in terms of safety. Patient care planning, assessment, monitoring, that whole piece of just vascular access device care and the infusion administration. Interpersonal communication and collaboration. I mean, we're not working face to face with our physicians, providers, pharmacists. So we have to, find ways to communicate via telephone and via interim people, et cetera. But we have to make that work. And patient and caregiver education is paramount. It's what makes it different in home health because they are at home with these vascular access devices, maybe giving their own infusions, and they have to be well educated. The very first article I ever published, was on patient education with home infusion, because that just struck me, becoming an ICU nurse and going in and saying, oh, we can't even do this for them. We have to teach them how to do it themselves. It struck me.
Right. And that's one of the things I noticed about this chart. And I'm one of these sandwich generation people where taking care of a kid in elementary school and having adult parents that are, end of life and having to do that work. And so as I look through this chart, it makes me think about that caregiver education, and the patient isn't always on the top of their game, obviously, when they're home. And when oftentimes there's, I did it with my brothers. There were multiple caregivers. How do you make sure the whole chain of command and everybody knows what's going on and is educated properly? It seems like a really tough task.
Yeah, it can be challenging. I mean, oftentimes if we're talking about home infusion, we're dealing with, 1 or 2 caregivers, but certainly we have to ensure that they're competent and know what they're doing. I was recalling one patient. Now this was wound care. It wasn't home infusion, but similar. You could certainly make the analogy, but it was a lady who lived in a farm area north of where I live, kind of out in the boondocks, and she needed a lot of wound care. She had developed some bad wounds, pressure ulcers in the hospital, came home. She lived alone, but she had 5 children. And of those 5 children, there were 5 wives or daughters and daughters-in-laws. And what they decided to do, they were totally involved in caring for her, is each of the daughters or the daughter-in-laws each did a week with her. They stayed there for a week. They did her wound care, and then the next one would come along. So I had to basically, teach all 5 of them. They did a fantastic job, but very committed as a family. But it became, a little bit challenging because she did have somewhat complicated wound care. So, but
well, and then the other part of that stood out to me was the interprofessional communication, and how do families and nurses and doctors that are prescribing and everything, how do you get that communication right? That's complicated too.
It is. But you just have to figure out a way to do it, and it's going to be different in some cases. I mean, sometimes we're working with physician providers who, they're okay with texting information. It depends on how sick that person is too. I can remember one patient, I remember him so well because he would send me a Christmas card every year after that period of home care because he was close to death in the hospital. He had a necrotic pancreas. I can't remember everything that was wrong with him, but his doctors were so involved too. His primary doctor, the infectious disease doctor, in a case like that, I had total communication with them. We would talk like almost every day because we were changing protocols to
Uh,
manage him and keep him out of the hospital. And sometimes if it's a patient on simple IV antibiotics, I mean, they're not having problems. The communication is going to be straightforward. We'll make sure they get the lab work if it's ordered, communicate that between the pharmacy, provider, us. So
yeah.
sometimes it's easy, sometimes it's more challenging.
Well, let's keep going on the slides and let lead us through this little bit.
Yeah, I kind of alluded to that on the previous slide in terms of education. One of the things that I also do in my own, consulting business side is look at lawsuits. And I've looked at a number of home care lawsuits that have involved home infusion therapy and complications thereof. And the, outcomes have been death, loss of limb, severe complications such as loss of hearing or balance as a result of an ototoxic drug. And really looking at some of the core problems, just failing to identify signs of problems or identify adverse drug reactions, incorrect programming of infusion pumps. I've looked at a couple of cases of that where patients have actually died. So really sad. I try to use some of this in the education that I do to our nurses just to make them aware and really emphasize that importance of assessment and understanding. You can't just administer things without knowing what you're doing. You have to understand the risk involved. And you have to, pick up on those changes in condition early because some of these were they were all preventable in my mind. And that's why I'm so big on education because, some of these nurses involved in these cases, their organizations didn't provide them with enough of a grounding and competency in home
Hmm.
infusion. So
Right.
that's kind of where I come from on that topic.
So are there some situations, common situations that are just very different from being in a hospital that are in the home from a clinical support type environment?
Yeah, I mean, in general, you don't have all of that ready clinical support. You're working in a unit or on a hospital floor, whatever. You've got other people there to say, I think something's going on here. Can you take a look or whatever? It's really all on the individual clinician,
Mhm.
and again, based on their, understanding that something may be going on. There are resources, and I emphasize that all the time. You may be alone out there in these homes, but you're really not alone. Your manager is only a phone call away, or your educator. You can connect with people if you're not sure of something. And I think that's really important. The difference, I think, between home care and acute care is you tend to work with more similar populations than in a hospital setting. Now, if you're working for a big home infusion pharmacy, you may be the nurse that's only doing home infusion. But then you've got these home care agencies that do home infusion, but it's probably not the only thing that they do. So on any given a day, that nurse may be doing, IV antibiotic infusions or somebody who needs diabetic teaching or they're in heart failure. So, they have to have
Mhm.
this broad expertise as well as some specific expertise as well.
Mhm. That's amazing. That's amazing. So, do you think home health care situations lead to more lawsuits than the hospital, or is it similar, or what?
I don't think you can say that. They do a report every 5 years, nursing service or NSO, CNA. It's online, people can look it up, but they do a report approximately every 5 years of closed cases. And it did show in the 2020 report that there was an increase in home care liability cases from like 12% to 21% or something like that. And it had dropped in hospitals. But they make the point, and I think this is very true too. It's not because nurses and home care are more negligent or anything, but we just have so much more movement of getting patients out of the hospital sooner, with significant conditions to manage.
Right. Sicker people coming home. So
Yeah,
you're going to have
exactly.
more issues.
Exactly.
All right. Take us through this one.
Okay, so This is part of the classes that I do, just a little, we pulled some snippets from things that I teach about, but I really spend time teaching ANTT, aseptic non-touch technique, which has been endorsed by both the Association for Vascular Access, and also it is in the INS standard starting in 2021, if I remember correctly, and certainly will be in 2024. And just trying to understand the importance of site care, okay, the key site, where that's ANTT terminology, key site, but the key site would be, where is there the break in the skin with the vascular access device, and the importance of just routine dressing changes and the frequency of changing them, and helping nurses to understand that you can't bypass this, that you do get bacterial growth underneath these dressings. And if we're talking about reducing our risk for infection via that extraluminal route, our site care is extremely important. And it's extremely important too for the nurses to understand the kind of dressings that we use. That's another challenge in home care. In a hospital, you have kind of the same products that you're going to use. You don't have multiple products. While
Right.
in home care, our Ascension infusion pharmacies, we have specific products we use, but we also work with different national pharmacies as well, depending on reimbursement and all kinds of other things. So nurses in home health have to be familiar with different brands of products. Okay. And I get some of those questions quite a bit. Okay. We use one product, but then another product comes out and there's some differences there, and helping them to understand that, that there needs to be ongoing education. You may need to watch a video, and I'll give them a link, how to
Yeah.
use this product specifically.
I find even when I go to a trade show that I haven't been to in 6 months and I put an adhesive on for the first time, I'm like, now what peels off of this and what stays with what,
Exactly.
yeah. It's
Yeah.
complicated.
I know. When I worked just in Wisconsin, where I reside, it was much easier for me. And now I'm working with, agencies in 10 different states. So they will see differences, and I emphasize that. In terms of a securement, I was actually talking to someone about tissue adhesive during the ABA conference last week. I mean, we aren't seeing it. I know it's being widely used in some hospitals, and it's not being necessarily used in home care, but nurses need to understand that if patients are coming out with that, what are they going to use if our pharmacy doesn't provide that? What I see primarily used, and this is my opinion based on what I see in the home infusion market, is probably still a lot of use of adhesive securement devices and increasing use of integrated securement dressings, all-in-one
Okay.
dressings. I haven't seen a lot with the subcutaneous anchor securement systems. I think that's an interesting option. But again, nurses have to be educated to that product as well,
For
because you
sure.
can't just pull it out. Okay, you have to know what you're doing at the end of the care if that patient needs their line pulled.
So,
And I mean, yeah.
I look at this, these are all great products and things that help prevent the IV complications. What do you think the standard of care is with these in at home care right now?
I think the standard of care is we are using, in general, we're going to be using some type of securement product. Okay. I think that, certainly, throughout our wide organization, we are seeing use of a securement product. And as I mentioned, I would say it's probably maybe 50-50 adhesive securement, and the other half probably integrated dressings. I'm not seeing as much with, at all with the other two options.
Okay.
But I think it's really
Glue has not
important.
made its way into the home yet, quite so much.
No, not really. And I think that it's important to educate nurses, and I have a little, I didn't share that one, but, just a little model of that as well. Because when we're looking at that ongoing, post-insertion care, it's, it's the dressing removal, it's the skin antisepsis, it is the use of some type of securement system as well as a dressing, and they could be combined. But nurses need to understand it's a whole package. It's just not plopping on a new dressing. It's doing what we do
Right.
to reduce that, inadvertent removal, to some extent.
Right. All right, let's keep going. I want to make sure we stay on time, and for those of
Mhm.
you that are participating, I know that we're going to get to the part that's the most exciting for you. You're probably interested in the new standards that are coming out in January, and although Lisa can't verbatim go through what they are, she can allude to some of the things that are happening. And so she's put together some slides for us that talk about trends, things that are coming, and we'll walk through some of that. And
Yeah.
if you have some questions, I'm sorry, but if you have some questions, please go to the
Yeah,
Q&A and plug them in, and we'll try and take those later on. So go ahead, Lisa.
sure. Eh, as Van said, I can't talk about specifics. And Barb Nickel, the chair, and myself as co-chair of the committee, we did present this to Ava. So we have a few slides from that we utilized. And I thought I would focus in on pain management a bit because it's so underutilized when we look at some of the surveys and things that we've done. But there is so much literature out there supporting the need for pain management with needle related and vascular procedures. And I really focused a little bit in on, neonates and children. It is extremely important that we address the pain management issue. You will see in the 2024 standards compared to 2021, a lot more references. I'm trying to remember off the top of my head. I think there's like 91 references in this section, and a lot of big research papers, meta-analyses looking at different options. But when we look at like the neonates, the sensitive developing nervous systems, they can be affected by all the painful procedures. And I shared at the AVA, convention, I'd never been in a NICU before. I've only done adults, okay, and older children. But my grandson was born prematurely, about 3.5 pounds, and he was pretty sick in the NICU. I mean, they did do a wonderful job there, but he did develop a BSI and had to have PIC and the whole thing. But a lot of needle-related procedures, and I did talk to the staff about that, and I was pleased that they were, providing intervention for him. And he's doing great now. He's a 1.5 years old. So and then when we look at children, okay, and especially, I mean, for any kids, but then if you look at some of these kids that need repeated infusions, for example, it leads to long-term consequences, procedural anxiety, hospital avoidance, needle phobia. I had an experience where I was asked, we had one of our patients was being seen in our ambulatory clinic in our pharmacy. And the nurse that was assigned could not get a peripheral IV in this girl. She was a teenager who had an GI disorder and required ongoing biologic infusions for that. She'd been getting them for actually quite a few years, but her needle phobia was out of this world. I could almost not get near her, okay? I could see decent veins, but she would just pull back every time I got near her. And finally, we just had to stop. I mean, her anxiety was so awful, and it had been the norm, and we were using EMLA cream, distraction, everything, but you look at that history there, and I've seen that before. So we have a lot of research that looks at distraction with children. What do you call it when they put like headsets on?
Virtual reality.
Virtual reality. I mean, there's some very good studies on that. And that's more complex, a little bit more expensive. A lot of hospitals or whatever wouldn't have that. But even just looking at different types of distraction techniques, television, anything that would work for them can help. And it doesn't completely take it away. I remember reading a quote from a kid that used the virtual reality. He said, I still felt it, but I really didn't care because I was so interested in the game.
Right.
I thought that was kind of cute. But I mean, in conjunction with, we have a lot of pain management options as well, direct pain management options in terms of jet accelerated lidocaine, EMLA cream, etc. We just have to employ these. And that interesting study, and I know I can go off on this too long, but adolescents, as they grow up, less attention to pain management. We'll pay more attention when they're little kids, but as they get older, we'll assume they're like an adult, so we're not going to worry about it. We have to think about that for adults as well. So there's
And
plenty.
you made that point. You made that point at the AVA meeting that we do all this for the little kids. Why don't we just do some of it on adults even?
Exactly. Exactly. And the new standard will support that as well. And it did in the past as well.
Yeah, it's awesome.
Yeah, so site protection, this standard is developed a little bit more, but we kind of redefined, site protection. Okay, so we talk about, a securement device at the, to pull it, to avoid any kind of, line coming out at the actual site. But we also have additional strategies that we can use that are going to prevent inadvertent dislodgement. And, Vance will talk about one of those, moving on, but we have a number of products out there that can be used to additionally provide that additional almost secondary securement to prevent that line from being pulled at the site. It also addresses the potential tampering. And I know I have another slide here that discusses like the person who uses injectable drugs. Okay. And we do have increasingly more and more of these patients in our hospitals. In fact, I was speaking at a local AVA chapter last night and was talking to a nurse from one of the hospitals in Wisconsin who said she is super concerned because she is, looking at placing lines. They have a pretty hefty population of drug abusing persons. So there are products out there that can protect from potential tampering. It's more of a tamper evident than preventing. I think we have to have a real humane view towards that patient population, though, which is on another slide. And we need to protect from water exposure. And one thing I looked at, just being at the AVA conference, looked at some of the products that some of these patients, these long-term patients are, developing and selling and getting, approval for products that work quite well to protect their lines, because that line is their line and they want to protect it. They don't want to have it replaced, whether it's from inadvertent dislodgement or from water or something that's going to allow microbes to get in and cause cause an infection. And then it also addresses restraints. And I think we did a better job in addressing restraints in the next standard because there's still a pretty hefty use of restraints in hospitals, particularly in intensive care units. And there's also literature that really supports that we can do better with that, because restraining patients can actually increase their anxiety and their feeling that, they're being tied down and they're going to get more anxious. And can we avoid that? So we want to think about protection, and there's a number of ways we can do that without getting into the details in that standard. But how do we limit use of physical restraints? And there's some good references there. Mm-hmm. Sub-Q, very quickly, it's an alternative to IVs. It really is considered like vessel health and preservation. If we have that patient who has really poor vascular access, they may be able to get fluids via the sub-Q tissue versus an IV, and we can preclude starting that IV. It works very well. I always feel like it's a sell job, though. I have to sell it to somebody. So it's like, because we just don't, it takes so long to get practices into like daily practice, and IV is the first thing you think of in somebody who's moderately dehydrated. But if they are dehydrated, their vascular access is probably poor due to that, or because they're older, they just have poor veins. It's something that we can do, and it's easy, inexpensive, and pretty much painless for patients. When we've done it,
when you say you have to do the sales job, is that on to the physician or is that to the patient?
More to the nurses and the physician.
Okay.
I'll sell it to the nurses and I'll say, okay, I'll make that call. We can talk to the doc, or you can make that call. The docs are actually open to it. They just don't think of it. It's not going to be the first thing on their list unless they're really working in the area. But when we've done it, it's been very successful, and it certainly is an option.
No doubt.
And then in terms of the new standards, we certainly are seeing more anti-neoplastic and biologic therapies. There's just the sheer increasing number of these products. And we have to be very careful before we move them into the home setting. We have to consider safety, whether they're hazardous drugs. It's not to say we can't do hazardous drugs in the home, but we have to have everything in place for that. And adverse reactions, in terms of, severe reactions such as anaphylaxis. There needs to be a very careful look before you say yes to administering any biologic therapy. And are your, nurses, pharmacists, et cetera, really prepared to understand that infusion and manage it? And then, as you transition patients from an acute, say, to the home care setting, really do a careful job. And this is outlined quite extensively in the standards, all of the things that really need to be looked at. I talked to guests about the home care organization preparedness. All these things are kind of repetitious here, but they're incorporated in that standard.
Okay. That sounds like that will be important and helpful to everyone.
Mhm. Okay, this is a slide that speaks to some of the literature that I spoke about at the ABA conference. And what can we care for these patients who inject drugs? That PWID is a well-used acronym in the research literature. And the research literature does say that we can take care of some of these patients at home, that they don't tend to abuse their bad or misuse it, but it involves careful transition planning. Okay. And some of I don't want to go into all the details here in a short period of time, but are they going to a safe place? Is the patient really engaged? Did they not use any illicit drugs, during their hospitalization, no behavior, and agree to that follow-up. So we can do that. We have to do it in a humane way. If we can get some of these patients out of the hospital, certainly it's good for our society in terms of saving money and everything and getting them, to a safe place. So I think there's a lot of fear often from doing that. And we have had cases in the past where we have to go in and put a peripheral IV in every single day. Is that really humane?
Right,
So
right.
we have to look at these in a very individual way, but we don't want to automatically say, no, we can't do it.
Yeah, and I was surprised. We'll see my company's product here in a little bit for a brief moment, but I was surprised when we were coming out with that product and we were attending conferences. Those were the very first questions we had were about tampering with the device. Could a drug addict infuse through it? Could they put a needle here or there? And I always walked away thinking if they want an injectable drug, they're going to figure it out one way or the other and get around most of the things. I mean,
Right,
they can obviously put a needle right into IV tubing if they want to.
right.
So yeah, so
Yeah, I
but I was
know.
surprised at how and that was 2015, 2016. So it just continues,
Hmm.
obviously.
Yeah, no, it's becoming even more of an issue now.
Let's go to the next one, Zoe. Thanks.
Okay. Yeah, this is just the midlines or the patient education. This one, I don't know who is in our audience and if you're home infusion or in hospital or whatever, but we care for the biggest category of home infusion is going to be your antibiotics. And this was a small qualitative study, but very well done. And it just speaks to some of the issues that happen as we transition patients and make assumptions, et cetera. Okay. And I see this in practice. I guess that's why I zoomed in on this study. It's Sarah Keller is the primary author. She's an infectious disease doc out of Johns Hopkins, and I've actually worked with her on the OPAC guidelines. So I love that she's really has kind of a program of research related to home infusion. But what was identified there, the misleading information as he transitioned from hospital to home. It's always like last minute, let's get this patient ready and teach them quickly here and then get them to home and rush through the instructions. And nurses teach in different ways and often give different information to patients. That happens a lot. Instructions are confused. We need to do a better job of transitioning and patient education to be more consistent. Again, this is something that I spend a lot of time on in my organization. I put together like a little job aid, like visit by visit, what are the things you need to focus in on, but also recognizing the barriers. For some patients, they're afraid. They've got this line in, it's near their heart and they're scared, or they're just in pain, or they're just overtired from the hospital. They aren't in a place of readiness to learn either. So we have to really teach patients carefully because this is a risky thing. They can make mistakes.
And this next slide is about midlines, and it seems like there's a lot a lot more usage recently, and people are kind of stretching the indication in a sense. And
Mm-hmm.
so it's always good to hit on this and clarify things for people.
Yeah, I will say I also chair the Vesican Task Force for INS, and we're doing our symposium next week. But one of the things we really have focused in on is midline catheters. So we are actually this one is going to be led by Lynn Hadaway and Barb Nickel. And I'll be like the third person on this particular paper, but we're doing a separate paper, just looking at midlines and all of the research out there and, risk of extravasation, infiltration, et cetera. and just doing a real deep dive into midlines. Obviously, they're widely used, especially with a lot of avoidance of central lines in hospitals due to fear of eclampsia. But it is a peripheral catheter. There are issues in it, some of the issues, catheter to vein ratio, and we do have studies that support, smaller catheters and larger vessels, less than 45% in midlines as well as PICs. And that will reduce some of the thrombotic risk, which is quite common with midlines. We have patency issues, which is a real concern if we're administering vesicants, because midlines are notorious for not readily obtaining blood returns. So assessment, again, is really careful. And we're seeing, vesicant infusions such as vasopressors via midlines. Now, the INS standards do clearly state from 2021 to not use them for continuous vesicants, PN, or infusates with extremes of pH or osmolarity. The research is just growing in that area, but we have to do it with a sense of safety. One of the problems is, if you look at a PIC versus a midline, they're placed in the same, approximate area of the body in the upper arm. And is it a PIC? Is it a midline? We're not consistent about labeling that. And we had an occurrence a number of years ago where the patient had a midline catheter and the nurse thought it was a PIC. There were complications, and the family was quite upset with us. Actually, it's like, why did nurse not even know what kind of line it is? We need to make sure that we have reports. We had to, look at the reports. What type of line is it? Where is the tip, et cetera, et cetera. We have to know our catheters. And in general, the guidance is, you can put a midline in for about 2 weeks of therapy, non-irritating type of therapy. But there's it can stay in longer if it's functioning well. And sometimes we do have patients with midlines that do last longer than that. It may have been put in for 2 weeks of an IV antibiotic, but then that antibiotic is extended by another week or two. So, I had a pharmacist call, well, we'll have to pull that line out, because it's been 3 weeks now, and yet everything's working just fine. No, we're not going to pull that out because it is a functioning line. On the other hand, we have to watch it carefully for complications. So I think midlines are going to continue to be an issue. And as I mentioned earlier, just in terms of the tip placement too, and some of the literature looking at different deeper tip placement.
So you made a point about talking to vasopressors at the AVA meeting. So do you want to hit on that here as well? I didn't hear that during this.
Yeah, that really is my chair with Barb Nichols, expertise areas of critical care nurse, but there's certainly a lot of vasopressors that are given peripherally. There's not this jump to put in a central line. Okay. And in the sense of, safety and such, we can run vasopressors for a period of time versus a peripheral catheter, but we have to, administer those with a sense of understanding that these are vesicant drugs and they can cause damage. But we do have studies that will support the short term. Now, if that's going to be extended as that patient is critically ill, then we need to consider a central line for continuing administration.
Okay, awesome. Well, let's have a quick infomercial now about you talked about things that can prevent IV complications, and Linnaeus Medical is the maker of Safe Break, which has been cleared by the Food and Drug Administration for use on basically all patients 2 weeks of age and older. And the breakaway device can be placed in an IV line. We like for it to go at the end of the extension tubing where the needleless connector is, and the long IV tubing that goes to the pump. You can see what the device looks like here and what it looks like when it's separated. The whole principle of the device is that, as you can see in these pictures, in picture number 1, you can see a safe break placed in an IV line. And picture 2, you can see a force placed on that IV line. And then in picture 3, you can see how the device is separated to offload that damaging force from the IV line. And of course, the goal is to keep the IV intact and working. But when Safe Break separates, valves on each side close and prevent the loss of medication on one side and the loss of blood on the other side. This also causes the IV pump to alarm, so the nurse knows to come in the room and they can just change out the Safe Break that's placed in the line with a new sterile one and restart the patient's IV and avoid a needle stick. And I think one of the most important things, obviously, when you have a brand new device is how easy is it to use? How easy is it to learn? Well, the device has standard lure connections on each end, and you screw it into the long IV tubing and prime the tubing along with the device like you normally do, and then scrub the hood on the patient side of the equation, and then you screw the SafeBreak device in. So that's it. We say it's easy, one, two, three, and you're ready to start the infusion, and you have your line protected by a new breakaway device. And so I think that brings me to the question for you, Lisa. So this is a device that's been cleared for 2 years. And how often and how important is it to get, great scientific data on these new things? Is that normal? Does it take longer? Do people kind of slow walk out various studies and you guys are trying to figure out on the standards if it really works or not? What do you think about those things?
Well, it's extremely important to have studies to support the products. And, the gold standard, of course, is your randomized controlled trial. Otherwise, it's just a product out there that people can say lots of things about, but we don't have anything in the literature that really supports it. It may or may not work, but we need the studies, and we certainly need the studies to support them in the standards. We're, only going to cite, research and peer-reviewed journals in the standards. So that is
Right.
extremely important.
Well, I guess everyone's lucky, or the FDA is doing their job. They required a randomized controlled trial to clear SafeBreak because it was the first of its kind. There had never been a medical device that separated a medical line. And so a randomized controlled trial was required. Lee Steer performed this, and it's in the Journal of Infusion Nursing. But this is the important chart from the presentation, and you can see on the left all of the things that can cause an IV to fail. And you can see the control group had 144 patients, and the group that got the SafeBreak had 143. And we just go through each one to show that the control group had 18 infiltrations. The SafeBreak group only had 11. That's a 39% reduction. You can see dislodgements were cut in half from 8 to 4. And phlebitis went from 12 cases that required an IV restart in the control group only down to 5 in the SafeBreak group. And so no infections in either group. And you go down to the very bottom, you can see that overall IV restarts in the control group were 39. And in the SafeBreak group, only 22. So this is a statistically significant 44% reduction in overall IV complications. And the FDA required that we study how long it takes to change out a SafeBreak versus how long it took the nurses to restart these 51 lines that you see here in the study. And it only took 5 minutes to change out a SafeBreak, whereas the vascular access team at this hospital placed all IV lines, even peripherals, and it took them 86 minutes for an IV restart. So a significant time savings for a patient getting their treatment. Obviously, to only have a 5-minute delay in therapy versus a 86-minute delay in therapy at this particular hospital with an IV team placing all the lines. And I can't ask you, Lisa, what the new standards are going to say about it, so we'll just have to wait till they come out in January. But from your previous notes, it looked positive. So I'm hopeful. All right. So just a couple of ways that a breakaway device could potentially help in home infusion. It doesn't matter if it's in the hospital or at home, but we have this proven reduction in IV complications, a reduction in IV restarts. Is there somebody even there when a dislodgement happens and somebody has to come back to the house? Right. That's a big problem. And then obviously medication that is wasted in this whole process. And this brings me to a couple of questions about home IV care. Do you think that pulls on the IV line are any different at home than in the hospital? Or are they similar, or there's different situations?
I think the situations are different. I mean, I don't have specific data on this. I would say that, for most of our patients who have a PIC or a midline, for example, for IV antibiotics, they're only hooked up for, half hour, 45 minutes, and then disconnected. And we have a method where we, use a, a sleeve up top that they can tuck everything in, so they're not likely
Okay.
to pull out. On the other hand, if you do have those patients that are on a continuous infusion, it's definitely a risk. Things can come apart. I mean, patients at home are far more mobile in general than a patient in a hospital setting. So they're moving around their house, a patient on parenteral nutrition, for example. They're trying to be as independent as possible. They're potentially going to work even, carrying their infusion with them. So the risk is definitely there. I just don't have any data on,
Yeah,
how
there
often
there
that
is no
happens.
data yet
Yeah,
around that.
exactly.
I
Exactly.
think we're just now starting to study and understand pull forces on IV lines. It's
Hmm.
an area which is amazing to me for 100 years of IV use,
Yeah.
that nobody's really ever studied these
Hmm.
lines being pulled on. Well, we're at 5 minutes till the hour, so it's time for Q&A. If anybody wants to put anything in the Q&A, please do that. We'll let Lisa address it. If you scan this code that's on the screen, it takes you into the Linneus Medical website. So don't think that you're going to get Lisa or anything like that if you scan that. But so if you're interested in the SafeBreak product, you can scan that. It'll take you to our company website. But while we are waiting a little bit to see if anybody puts any questions in there, Lisa, do you have any home healthcare stories, horror stories of situations where lines got pulled out or things of that nature?
Yeah, I mean, I can think of a couple off the top of my head. I we used to do a lot more continuous, like 5-FU chemotherapy infusions, and I remember, we had did separate on call for that, so I did on call quite a bit for those patients. And I remember getting a call from a patient, and he was hooked up to his 5-FU infusion, and he's living alone. He's totally alert oriented and everything, but he just, yanked everything, dropped the pump on the floor, and pulled out the line.
Right,
So,
right, right.
yeah, which is an issue. It's also a hazardous drug issue as well. So I remember that. And I remember a horrible, it's not that horrible, but from the nurse's perspective, it was one of our nurses, very good nurse. Okay, she still works for us part-time, but she was in a patient's home, did PICC site care and everything. And the patient was, attached to an infusion. I don't remember what, but somehow in getting up, she stepped on the tubing and pulled the PICC out. She
Okay.
was devastated. you know, it's just a horrible accident. I mean, the patient was actually really generously nice about it, but had to have his line replaced. So, I mean,
Right.
things do
I
happen. I think,
I
yeah,
had heard the story of a nurse that had driven an hour and a half and had chemotherapy drugs and gets to the patient has a PICC or a central, and they get there and they ring the doorbell at the house, and the dog starts to bark and runs to the door and pulls out the patient's PICC right before the nurse
yep,
is there to give the infusion. So she has to drive an hour and a half back
yep,
home. Patient has to obviously, have the PICC redone, et cetera, et
yeah,
cetera. So yeah,
yeah.
there's lots of
Things happen. Things do
yeah,
happen, but
and they're
I
not
think
easily resolved when you've given that travel and all that
no,
that's involved
mm-mm,
in home healthcare.
right.
Well, I don't see any questions coming in, which is
Yep.
shocking to me to have such a wonderful resource available at the time to ask about a couple of things. I'm going to just close out then with go ahead and slowly go through the next slide, Zoe, that all of the references for all of the things that Lisa talked about earlier are available here on these slides. This webinar has been recorded and it'll be posted on our website. So if you have some interest in going deeper in one of those areas that Lisa was talking about earlier, you can access those references from this presentation on the website and dig a little deeper. Do your own homework if that's what you're looking to do. Is there anything that you'd like to say, Lisa?
I don't think anything additional, but thank you for the opportunity to present, and I hope that the attendees enjoyed it.
Yes, yes. Well, I enjoyed talking to you. We really appreciate you being with
Yeah,
us today. Thank you for your
me
help.
too. Thank you so
Okay.
much.
Okay. Thanks, everybody. Have a
Bye.
good day.